behind the rib cage. So it's a very awkward place. So if you think about it, to get there, from the front, you've really got to go right to the back of the abdomen and high to find these adrenal glands. So that's the first problem. The Lord put them in an awkward place, presumably because they are essential to life. I mean, 200 years ago, or maybe less than that, if you had no adrenal function, okay, which most of the time was because you had TB, TB can destroy your adrenal glands. If you have no adrenal function, you die. So if you've had a bilateral adrenalectomy and you forget to take your steroids for weeks, you're really in trouble because you can't function. So the good Lord presumably, much in the same way as they put the brain in a hard box, they put the adrenal glands in a very awkward to get to place because it's very difficult to damage them because of where they are. Now, if you go onto the internet and you look up adrenal anatomy, you get something like this. If only it were like that. Mm-hmm. If only. Because reality is, 500 years ago almost, we knew that the adrenal glands are far more complicated because like all endocrine organs, if you think about what an endocrine organ is, it's a gland which has no duct. So in other words, they produce hormones and they have to release these hormones into the bloodstream. So in order to do that, you have to have a very, very good blood supply. So the characteristic of the adrenal glands, like the thyroid, like the parathyroid if you like, and to an extent like the pancreas, is the blood supply is very, very florid. So when you do an operation, first of all, you've got to get to the organ. That means digging the spade till you get to the adrenal gland. Then, when you get there, you have to deal with the blood vessels that supply the gland and that drain the gland. And obviously, the more that they are, the more intricate they are, the more difficult the operation is potentially. So, this is a left adrenal gland. That's the kidney, okay? And the thing to notice here is that the blood supply is not single. You get arteries that come from above, here and here, which is the phrenic, so from the diaphragm, so that's one load of blood vessels you've got to supply, that's arteries. You get other arteries that come directly from the aorta, and you get other arteries that come directly from the renal artery. So you can see, you think, oh, blimey, I've got to deal with all three of these blood supplies. The venous drainage is typically by a single vein, okay? But in fact, there are so many variants that you can work an assumption there's probably going to be two veins you have to deal with. That's on the left. On the right, the situation is slightly different in that even though the arterial supply is from the renal artery, from the diaphragm, and directly from the aorta, the blood vessel goes behind this big blue thing here, which is the inferior vena cava, the blood supply, the blood drainage is via this short, stubby, slightly tricky, single right adrenal vein. So the message I'm trying to convey is the adrenal glands are in an awkward place, and when you get there, it can be a little bit tricky. So these are scans of the abdomen. This is a CT scan and an MRI scan. You can tell the difference because on the CT scan, bone is white. That's your vertebral column, and these are ribs. And on the MRI scan, the thing that's white is fat. Okay. So this is slicing through someone's abdomen. That's the liver. Okay. That's the aorta, and that is a large left adrenal gland. Okay. Here, that's a left, whereas this one, the adrenal gland is on the right. And again, you can see it's tucked right underneath the right lobe of the liver. And the inferior vena cava will be a little bit squashed around there. So that's the anatomy. But the thing to note here is, look where we are. The ribs. That's the bottom of the lungs, and these are ribs. So you're in the abdomen. When you think of the abdomen, you always think of this. But in fact, it's much higher, much higher. So, as a consequence of this, there's a general rule in surgery, and that is, the more awkward the organ is to get to, the bigger the cut you have to make to get to it. That's traditional surgery. So there are lots of different ways of getting to the adrenal gland. This is called a midline laparotomy. You might have a rooftop if you're having bilateral surgery, or unilateral subcostal if you're doing one-sided surgery. You could have this big incision for bigger tumours is a thoracoabdominal incision. And this operation was very popular, and where I work, which is the Hammersmith, my predecessor liked this operation. He liked this because even though the incision doesn't look very nice, and you have to excise a rib frequently to get to the adrenal gland, which is quite painful, despite all that, it's less painful and less troublesome than if you go from the front, because when you go from the front, you have to negotiate all those other organs are in the way, the liver, the spleen, the pancreas, and so on. So you can see that these operations here are all fine, they're all strategies to the adrenal gland, but this was quite popular because it seemed to offer an advantage, and I'll show you the numbers of our data in a moment. But as you can see, it's a big scar. It's a big scar. And when you have a big cut, you have a lot of pain. What we've done is we've replaced a big cut with long instruments. Why? Because what really the big transforming thing in surgery over the last 20 years is fibre optic scopes. So in other words, now we have the ability to put a camera inside you and magnify the image. And then once you can do that, you think, okay, well now I need some clever instruments that allow me to manipulate things inside your tummy or inside your body compartment, so I can do the same operation but without making a big cut. Now, the great advantage, the biggest advantage of these operations, it relates to when the organ is in an awkward place, because organs in an awkward place are the ones that have the biggest cuts to start with. Also, as a principle, the biggest advantage was when the trauma of access was bigger than the trauma of taking the tumour out itself. What does that mean in layman's terms? Well, once you've got to the adrenal glands, let's say your adrenal gland's that big. Yeah, it might be much bigger, but let's just say you've got an adrenal gland which is 2 centimetres, okay? Once you're at the adrenal gland, the trauma actually is not great. You've just got to control those little blood vessels and be very careful. The trauma of the operation is all the access. You've got to make a bloody great cut in order to get to it. So those operations where all the problems are related to the trauma of access, and in other words, getting there, are the ones that most benefited from this surgery, which is laparoscopic surgery. So this is the laparoscopic adrenalectomy. And the interesting thing is, you know, in medicine, we talk about something called a randomized controlled trial. In other words, when you've got a new drug, you can compare it to either nothing or another drug, and the patient mustn't know what they've had, and the doctors mustn't know what they've been given, otherwise it might influence the results, and so on and so forth. That's called a randomized controlled trial. In surgery, it's almost impossible to do randomized controlled trial, because how do you blind the surgeon? What do you say to the surgeon? Well, you don't know what operation you're going to do. Or you can't say to the patient, I'm going to consent you for an operation, but I'm not really sure what it is. and it just won't work. So laparoscopic adrenalectomy, despite the absence of a randomized controlled trial, from the late 1990s became the unequivocal gold standard operation for small benign adrenal tumours. Because basically, it's so obviously better that if you choose a big cut like that, or 3 or 4 small cuts like that, immediately just looking at it, it looks like it's much better. But then there are other factors, and the most important factor is complications and recovery time, which are much, much shorter. Now, as always happens in surgery, you start off with an operation. You start off by doing the least complicated, the most straightforward cases. So everybody said yes. For small tumours, that's fine. But then, of course, as we all know, what happens? because we think, well, actually, I'm sure I can take a larger one. And so we started off by saying only less than 4 centimetres. I've taken out a 9 centimetre adrenal tumour laparoscopically. So you've just got to be sensible, okay, because you've got to know when to realise there's a limit to the technical feasibility. But you can take out rather large tumours, 6 centimetres routinely now. On Monday, I have a 6 centimetre pheochromocytoma on my list, which, even though it's a little bit complicated, I expect to be able to do laparoscopically. And now, we're doing this as well. So if you've got a cancer somewhere else in your body, and it spreads to your adrenal gland, we're now taking out the adrenal metastases via this laparoscopic approach. So basically, laparoscopic adrenalectomy is the gold standard, or has been the gold standard. So do you need a randomized controlled trial? You don't. This woman had a pheochromocytoma, and that's 2 weeks post-op. So obviously this is immediately post-operative, but do you need to do a randomized controlled trial to show that it's a difference? Well, the good news about you people is that your genetics mean that we can randomize you effectively, but involuntarily. So here we are, a von Hippel-Lindau syndrome is another genetic syndrome which predisposes you to pheochromocytoma. She's a slim patient, okay, which is what we all like. She had a right adrenalectomy done by my predecessor, a very experienced surgeon, in 2001. The operation took an hour and a half, and she spent 9 days in hospital. That was normal. She's had a good operation, but it just takes a long time to recover from a big cut, because it's painful. We have to cut muscle, and the recovery is longer. In 2006, he wasn't very happy when I did a left laparoscopic adrenalectomy on the same patient for a pheochromocytoma. The pheochromocytoma was actually slightly bigger than his one. The operating time was the same, and she spent 2 days in hospital. And there's another factor, that when you do an open operation on an organ which is very far away, it's not uncommon that you can't get it all. And this is no criticism of the surgeon. That's the way it is. It's just very difficult sometimes. The beauty of the laparoscope is it magnifies everything. So instead of, if you're dealing with something which is that big, on the screen is about the size of this picture. So everything's really magnified, so you can see everything much better. In fact, if you really want to know, it's more scary, because every blood vessel looks much bigger. If you've got 3 red blood cells, you go, oh my God, what's happened there? In fact, if it was open, you'd get a bit of a mop, and you go, oh, there's nothing. What's the big deal? And initially, it's so scary when everything's magnified. So the point is, do you need to randomise? Well, you don't need to. It's obvious. And there we are. Look at the length of stay at the Hammersmith Hospital. Historically, open adrenalectomy, 9 days would be typical. This is the operation which that girl had. She spent 9 days in hospital. On average, you spend 7, okay? And then laparoscopic adrenalectomy. Average length of stay, 2.5 days. Now, so the reason's simple, you have less pain, you mobilise sooner. Now remember, it's not just about surgical bravado. Oh, my patient went home after 2 days. Aren't I clever? The problem with hospitals is they're full of bugs. So if you spend enough time in hospital, and you're a little bit immunosuppressed, or you've got a wound, the longer you spend in hospital, the more likely you are to pick up an infection. Secondly, the longer you spend in hospital, the less mobile you're likely to be. Because in hospital, you get TV, yeah, you're in your bed, they bring you food, you buzz the buzzer, and then somebody gives you a cup of tea. Basically, you sit there, it's fantastic. I'd love to do it. In fact, sometimes I just think maybe I'll just get into that. Rather go home to my children, and I have to serve them. No. So in the hospitals, you're immobile. If you're immobile, your blood flow, in particular your venous blood flow, is not going to be as good. When you're at home, if I send you home, and you want a cup of tea, you have to get up and make it yourself. So you're mobile, so the blood flow is better, so you're less likely to get deep venous thrombosis. So wound infections, deep venous thrombosis, and the complications of immobility in general, like chest infections, are all much lower if we get you out of hospital. So short hospital stay is a good thing. So that's why it's worthwhile. Now, so what about this fast operation, this clever operation? Well, that is just another approach to this surgery. Now, this chap here is called Martin Volz. Now, most surgeons don't like to show pictures of other surgeons in their talks, or because they want to talk about themselves. But the reality is, people challenge this man, and they say, you didn't invent this operation. But this is an alternative approach to the adrenal gland. What he did, okay, whether you like it or not, is he perfected a technique. And that is combining the advantage of a laparoscopic operation, big screen, fibre optic scopes, clever instruments, with the benefit of going through the back. Because the back is the fastest way to the adrenal gland. So I've been to see this man twice in Germany, and I have to say, I'm immensely impressed, because he has perfected this technique. And the beauty of this is that surgeons don't always tell everybody else their secrets, but over a glass of wine, he will spill all the beans. He'll tell you everything. He'll tell you how all the mistakes he's made, how when this happens you should do that, and if you can't see this, it's because you're doing that wrong. He tells you the whole lot. So when you come home, you think, actually, I'm going to see if I can do this operation. And it's a daunting experience to do an operation where it's not an established technique in which you've been trained. So when as a consultant endocrine surgeon, I've done 200 laparoscopic adrenalectomies. So you think, I know this operation. I know, and I've seen every eventuality. Because not only have I done my own, I've watched other people's too. So you think, I know what can happen, how it can go wrong. But when you do a new technique, you're on the phone to Germany saying, what is it that I'm doing wrong that doesn't quite work? And that's why this operation is done by very few people in the UK. You have to be doing a lot of it in order to get any good at it. What's the difference? Well, the first thing you notice... No, there's no...
I'm glad it's not me.
The first thing to notice is this patient has an arrow. No. The first thing to notice is the position. When you have a laparoscopic adrenalectomy, like this, you have the side up, you're in this position here, you have the side up, which is going to be operated on. Okay? Is it uncomfortable? Well, some patients have sort of a bit of a muscular strain after the operation, but it's not a big problem. When you have a retroperitoneoscopic operation, you're in the, actually it's wrong, I call it praying to Mecca, but it's not really praying to Mecca position at all. It's basically you're laying flat, but it's very important your legs are bent, okay? Because this has got to be flat. Your back, normally, if you, I can't show you mine, because you have to be sort of fit. If you're fit and slim, you can see that your back has what we call lordosis. Your spine does that. We have to get rid of that curve in order to operate. That's one of the first tricks that you learn. If the back's like that, the access is much worse. So you've got to flatten out the back like that. That's the first thing. What else is different? Well, you know what? Very little. Because the instruments are almost the same. In the case of an laparoscopic adrenalectomy, you're simply putting 3 or 4 ports into the abdomen, into the tummy, and you're going through the front. And when you go through the front, you have to get the things that are in front of you out of the way in order to get to the organ. When you do it through the back, it's different because the adrenal gland is in the back. It's high and in the back. So, this is a laparoscopic adrenalectomy. Okay? Now the first thing to say is, you may be disorientated, but this is the liver. We're on the right side, that's the liver. Okay? And this thing here, this filmy stuff, is a peritoneum. Now the first thing to say is, this is a slim patient. Okay? Because when you show this to surgeons, the first thing surgeons do is start criticising. Hang on, yeah, he's chosen the slimmest patient he could find, and that's why. Both of the patients I will show you today are slim patients. So, as you can see, this is a diathermy hook, and what we do is, in order to get to the adrenal gland from the front, we have to do all this business here, mobilising the right lobe of the liver. This is a liver retractor, a laparoscopic liver retractor. Okay. Before anyone asks, how could the thing that shaped be put in the abdomen? Well, what happens, it's very clever. You put it in as a straight floppy thing, and then you screw it up, and it turns into a donut-shaped thing. Okay? So it's curved like that. So that's holding up the liver, and this is dissecting out. Now, the thing to notice here is I've edited this. This video is edited, so it's much shorter than the reality. This whole business, so far, has probably taken about 15 minutes, at least. And that's the big inferior vena cava, and you'll notice that we still haven't quite seen the adrenal gland yet. And you're going, by this time the anaesthetist will be going, oh, it's coffee time for me. So you've been there 20 minutes and you haven't even seen the adrenal gland. It's only now, having done all this dissection, that we start to see the adrenal gland. And the reason I show this is simply to show you that the operation hasn't even started yet. In the sense that the operation on the adrenal gland requires all this preparation, and we've not actually got to it. This whole procedure, so far, just getting to the adrenal gland, probably takes about 20 minutes on a good day. Now, there might be somebody clever, so, oh no, I do it, it takes me 14 minutes. Whether it's 14 minutes, or 20 minutes, or 25 minutes, it's always variable depending on the shape of the patient, how fat they are, if they've had previous surgery, and so on. And the thing about having previous surgery is very important, because if you have previous surgery, there's always a bit of scarring. So you've got to negotiate the scarring too. That, in fact, was one of the first reasons I got interested in this alternative technique, because when you're doing a lot of adrenal surgery, you get more and more difficult cases. And sometimes you'd spend an hour and a half just getting to the adrenal gland, because they've had a previous cholecystectomy, or they've had a previous colectomy, and you're just dividing all these adhesions, everything's stuck together. And when you divide these things, you're very worried about injuring bowel. So it's just a tedious procedure before you even get to the organ you're looking for. So that is a laparoscopic adrenalectomy. What I'm going to show you now is an unedited, you'll notice there won't be any cuts. Okay, so if you see a cut, put your hand up saying, he cheated. There are no cuts here. It is an uninterrupted approach to the right adrenal gland. So same side, this patient is also relatively slim. So we're comparing like with like. I'll let just one example, but then I'll show you the data comparing. Oh, now I need. Just try. Okay, here we go. Now here, this looks completely different, because what we're doing here is we're going into the back. Okay, so it's completely different experience. Now I know somebody's had this operation done by me. It actually would have been very similar, and our slim patient, who essentially what we're doing here is we're just opening up the space. And this is at fat around the kidney. Okay, that there is your spine, if you like. Okay, so that's the midline, the vertebrae there. And you'll notice that all I'm doing here is just opening up the territory. Okay? Lots of fat. The fatter you are, the more of this fat there is. But notice, no editing. Okay? No editing. And we're just bringing everything down. We know where the kidney is. Okay? And all we're doing is preparing the field. Nothing more than that.
It's just pulling it.
Yes, that's right. Just opening up the space, because basically just full of fat. And a few small blood vessels, but they're nothing. Look, these things here, they're nothing. They're really, even magnified, they're nothing. If in real life, these will be absolutely tiny. And the thing you'll notice is, what I've noticed already, is, and you'll see it much better in a moment, that that's the adrenal gland. So, in a minute and a half, 1 minute 40 seconds, or however long this video is, there's the adrenal gland. So there's no mobilisation of the right lobe of the liver. There's no fiddling around with bits of bowel which are stuck there from previous surgery. You just go straight into the back with a camera and instruments, and you go straight to the adrenal gland. From that moment on, the operation is exactly the same, because you've still got to control the same blood vessels, you've still got to do everything and mobilise in the same way. But the speed of access and the directness of access gives you advantages. And we're now up to, we've just published this is our published data which has been accepted. And we're now up to about 45 retroperitoneoscopic adrenalectomies. And this is a comparison of a retroperitoneoscopic adrenalectomy versus a laparoscopic adrenalectomy. Now this p-value is statistical. Okay, we use statistics to confirm that the thing is not just by chance, but it really is beneficial. If the p-value is less than 0.05, that means it's unlikely to have happened by chance. It's a real difference, okay? And I've put them in bold, because the ones that are statistically true are in bold. So you compare the patients, the same sort of number of female, as you can see, the statistics show there's no difference. Age is very similar. You can see that the patients we've done via the retroperitoneoscopic approach tend to be just slightly fatter, okay? That's just by chance. I didn't choose to do fatter patients that way, just by chance. ASA grade, that's the American Society of Anesthesia, or Anesthesiology to be precise. And that's just a classification system for the comorbidity of the patient. So you can see that essentially they're very similar. You might argue that our retroperitoneoscopic approach patients tend to have more things wrong with them. Yeah? So if you've got diabetes, or you're a smoker, and you've got bronchitis, or chronic obstructive airways disease and so on, you would fall into these groups here. Okay? Previous abdominal surgery, slightly more, but not in a significant way. Slightly more have had a retroperitoneoscopic approach. Which side? Very similar both groups, and the pathologies are also pretty much similar. The only thing that's different between these two groups is that the retroperitoneoscopic approach patients had slightly smaller tumours. So they were 3 centimetres in diameter on average, as opposed to 4 centimetres on average. So you could argue, well, you're not really comparing like with like. That is true, and there's a reason for that. Because you cannot do the really big tumours through the back, because there's not enough operating space. So what happens is, when you put the two groups together, it's inevitable that if you've got tumours of 7 or 8 centimetres in the laparoscopic group, that's going to make the average tumour size in the laparoscopic group higher. Okay, but this is not a huge difference. Okay, in the real terms, it's not a huge difference, because really the difference is about 1 centimetre. Doesn't make that much difference alone to the operation. Now, what I've done is I've put in red the significant differences here. This is the operating time. Now, we've done this operation, as you can see, this is what's called a confidence interval. So when you do statistics, you say, what's the average? 1.5 hours. And what's the confidence interval? In other words, how much variation can we predict? Well, you can predict 50 minutes variation. So in other words, we've done this operation at times of 25-30 minutes, which is incredibly quick. Now, we don't look at the clock. That's not what we're about. But sometimes you go, blimey, the operation took less than the anaesthesia. It's so quick sometimes because of the speed of access in a straightforward case. So there's a big difference in operating time. You know, we're talking about over 2 hours compared to less than an hour and a half on average. But so what? Half an hour? What difference does it make? And that's true. That's not a big difference. But how much sooner do they start eating? Well, you're eating after 4 hours after retroperitoneoscopic adrenalectomy. It's half a day before typically you start eating and drinking in a laparoscopic adrenalectomy. But this is when it gets interesting. What about the length of stay? The length of stay is obviously much shorter with a retroperitoneoscopic adrenalectomy. And the reason is simple, because you get less pain. It's as simple as that. When you go in through the back, it's not about spending half an hour less. What it's really about is you don't get so much pain, because the retroperitoneum, that fat, is not innervated. Whereas the front, that peritoneum that I was lifting off there with the hook, that's all very innervated. In other words, you have a nerve supply there. That's why when you get appendicitis, it hurts, because it's innervated. Okay? Whereas the back, not at all. And that's the big difference. So when my predecessor said, I prefer doing it through the back because the patients seem to do better, that's the reason they do better. So this is a few graphs just confirming it. This is the operating time. That's the confidence interval. That's the average. That's the confidence interval. You can see it's a much shorter operating time. You can see that you start eating and drinking much sooner, and you can see that the amount of painkiller, we use tramadol, which is an opiate, is much, much less in retroperitoneoscopic adrenalectomy. The thing to notice here is the variability. Patients are incredibly different. I mean, I'm ethnically Italian, and everyone knows that we've got a very low pain threshold. Okay? My wife reminds me of that all the time. She says, what it is about you Italians, everything hurts. Well, I don't know what it is. If you're Celtic, you're stoic, and I suppose, you know, you can put up with loads of pain. And like men probably have got a lower pain threshold than women. But in laparoscopic adrenalectomy, for some reason, some patients feel no pain, and some patients are bloody emotional pains. So I don't really understand. But here, it's predictable. It's predictable, and it's less. And this is another graph just showing you, green is retroperitoneoscopic adrenalectomy. The take-home message from this graph is, forget about the statistics, about the average. The vast majority of our patients go home on day one. If you have a retroperitoneoscopic adrenalectomy, the vast majority go home day one. Our long stayers are all for cultural reasons. We won't go into it, but basically some people are really keen to get home and some people aren't. I mean, one of the things you notice, people will say, well, if I have a thyroidectomy, how long will I be off work? If you're self-employed, 2 days. If you're a policeman, 6 weeks. It's true. I don't know why. I swear to you, I do not know why. But that's just the way it is. And the only officers of the law here, there's no offence, it's just the way it is. Just like the pain threshold is different. I just think it's, you know, maybe it's because you've got a strenuous job, you don't go back. But I have self-employed plumbers who go back to work after 2 days after work. And what about the cosmesis? Well, this is, you know, the cosmesis after a retroperitoneoscopic adrenalectomy is very, very good, with one added advantage: the patient can't even see the scar. So if you say, "What do you think of your scar?" they go, "Darling, can you have a look?" So they can't even see the scar. So there is that thing, and it is true that when you're on a beach, everyone looks at your abdomen and go, oh, you've got an appendix there, you've got a gallbladder there, you've got a laparoscopy at your belly button. Everyone can look at, but no one's sort of going at the back and you've got a scar there. You know, it is different. And cosmetically, having a scar on the back is probably better than on the front. And frankly, you can't even see these scars after a few months. So the conclusion, and what about that for timing, Joe?
Perfect.
The conclusion is that if you select the patients appropriately, this is not an operation that goes for all patients. There are some patients, if you've got a tumour which is not too big, less than 5 centimetres, and in particular if you've had previous abdominal surgery, the advantages over open surgery, well, forget it. The open surgery is off the scale. You can't argue it now. I mean, there is a centre, even in London, where people are still doing open surgery, but it's very difficult to justify. But retroperitoneoscopic is not only better than open surgery, which is obvious, but it appears in that group of patients that are well selected to be better than a laparoscopic approach. And as I say here, the vast majority of our patients go home on day one following retroperitoneoscopic adrenalectomy.
Can I just ask a quick question?
Yes, of course.
So, how many other people are doing this in the UK?
Well, myself and Barney Harrison have got the biggest practice. We're the 2 people that do it. But what's happening now is there's a sort of a groundswell of interest. So I'd like to speak to the American chap there, but the Americans are taking the big centres in the US, like MD Anderson and in Columbia in New York. They're doing retroperitoneoscopic. And what really convinces you is you just go and see the patients. When you see the patients after the operation, if you have a laparoscopic operation, which is a great operation, you see the patient and they've got a bit of pain. And if they've got pain, you give them opiates, morphine. Low doses, but morphine. If you take morphine, even if you have the other drug to stop you feeling sick, inevitably you feel a little bit drowsy. If you're drowsy, when the nurse comes round and says, anyone for tea and biscuits, you go, oh. So what happens is everything's a bit slower. If you don't have pain, we don't numb you in the same way. And so everything's a bit faster. Once you've had that experience, I remember my first 3 or 4 retroperitoneoscopic adrenalectomies, I just thought, obviously at the beginning I thought this operation's a bit tricky, it's a bit awkward because you're not quite so confident because you haven't done it so many times before. when you see the patients after surgery, you go, my Lord, this is a night and day. There's just a huge difference. So at the moment it's myself and Barney Harrison in Sheffield, the biggest practice, but I think there are more people starting to do it. The real problem here, as Professor Kareem Miran was mentioning, is one of the problems we have is that when a new technique comes out, surgeons love to try it. There's a learning curve here. You know, it takes a while. You know, I'm in mid-40s, upwards of 46, 47 cases of retroperitoneoscopic adrenalectomy. And I've got the biggest adrenalectomy practice in the UK. I do 45 adrenalectomies a year. So that's me. So I think that the learning curves, I like to think it's all plateaued now. But initially you are learning, and there's a lot of cursing. So there's no, you notice there's no microphone there. Because there's a lot of cursing. Oh, what is this? This operation is crazy. But the reality is that there will be, you'll find the big centres will take it. In Oxford, there's a lot of interest from Radio Lehigh to do this.
How long has MD Anderson been doing it?
The woman there is called Nancy Perrier, and she has been doing it for about as long as me. So I think she's been
experienced.
Yeah. So I think we're looking at 3 years, 4 years.
So do you find people travel to you?
Yeah, and what they do is they say, "Can I come and see you?" And I say, "Look, it's very flattering." And everyone says, because my registrar, what happens is my registrar leaves. He goes to another hospital, and then that hospital contacts me and says, "Oh, I've heard this operation is really good. Why don't I come and watch you?" And my registrar, everywhere my registrar goes, I get the same communication. I always say to them, you know, I'm happy for you to come and watch The Apprentice. But if you want to watch The Master, go to Germany. Because not, you know, at the end of the day, Barney Harrison, myself, the technique is there. But he will do in one day, if you say to him, "I'd like to come watch you do this operation," in one day he'll do at least half a dozen adrenalectomies, just to show you. And I've been there twice. On one day we did 9. We did 9 adrenalectomies. And he's a sort of an old friend now, because I met him a decade ago, more than a decade ago. I'm showing my age. I met him a long time ago, more than 12 years ago, and he was just talking about it. You say, "This technique, I do this, I do that," and he said, "Oh yeah." But then I went to see him the first time in 2004, because I was doing endoscopic parathyroidectomies, and he invited me. Well, he invited my boss at the time when I was living in France. He invited my boss, and you know it's like when you're the boss's boy. He sends you. He goes, "Oh, I'm busy. Let's you go and do it." I went there, and he was running a course, and I saw it the first time then, and I thought, this is a clever operation, but it just is looks a bit difficult. That was my first impact. And I've known him since that time, and even before then. And then I went back to see him again in 2011, 2010. And he's a very kind man. He set the thing up for me. He said, you come and hold my camera. I'll show you how to do a bit of it. And you do the operation, and then you do the ward round of these 9 patients, okay? You go to the ward round, and the patients are sitting there eating steak. There's one guy, in German hospitals, they allow you to have a beer. You have a beer like that, with froth, all the big head of beer, and he's getting stuck into his steak. You know, normally you go and say, "How are you?" And they go, "Oh, I'm all right, I've got some more painkillers." This guy's got a steak. This guy had a big operation this morning. I mean, if you think about how we've got there, from an open adrenalectomy, which is I still do open adrenalectomies, when you simply have no option, or there's a problem during the operation, you have to do an old-fashioned operation. Those patients, it's like going to prehistoria, because they're still in hospital after a week, going, "Oh, you know, what have you done to me?" And it's all about access, big cuts are painful, and the visceral pain. The pain from the peritoneum is, you know, it takes a long while to get over.
Are the tests still the same? 3 24-hour neuromonitor tests?